very, very unfortunate to leave behind two small little children. And I'm sure this entire this mishap will be reflecting them throughout their life. It will be a nightmare for all of them. We hope and pray the Almighty gives them the courage and the strength to stand and overcome these difficult situations. As a strong Foxy body, I wish the Foxy will take great measures to see such things do not occur in future, to have certain law and order, to help all those, similar situations. We should have some guidelines as to what is to be done when we face with such a situation. Failing which, I'm sure nobody will want to do obstetrics because people, it's so scary. For something which happens so regularly, it's unfortunate that that particular person died. But to face a consequence, such a dire consequence, is very, very, not at all acceptable. And we strongly condemn what has happened towards Archana Sharma's madam. And I'm sure Foxy would leave no stone unturned to do such something is being brought about, some law order is being brought about towards this situation. With these few words, let me move on to today's meeting. And this is a very apt topic today in the current situation. Now, so for every maternal death which happens, at least a few or quite a lot more, maybe around 25 to 30 people might be having some sort of a morbidity. Some of them might be very severe. And what is exactly a near miss? A near miss is a condition where a person almost died, but she recovered from that event and then she survived. So that is what is known as near miss. So in near miss, WHO has categorized certain conditions as near miss. It could be clinical conditions, it could be investigative conditions, it could be some interventions that we've done, like it could be a laparotomy, it could be a hysterectomy, or some interventional radiology, or it could be some severe clinical condition like preeclampsia, rupture uterus, sepsis, etc., or organ dysfunction. So it is classified. I'm not here to talk about what exactly is the near miss, but I'm sure we come across all these situations day in and day out. And most often it's a success story. Most of them will overcome it, but sometimes, unfortunately, they succumb. And then it becomes a maternal mortality. Now, the events which causes maternal mortality and near miss are the same. How is it that one person survived whereas one person succumbed to it is what we have to know. What did we do in that particular person? How we could make that particular person survive and how we lost the other person. So everybody is very, very happy to talk about near miss because it's a success story. They have done something. They would have done the same thing for the other person also. But something in this particular person clicked, and that is why that particular person survived. So we have to discuss from 4 different societies, 4 different cases, and we should be able to learn what all they did in those near miss cases and how did the person survive. Though left alone, she might have died. How did that particular individual overcome that and then she survived? So that is why we have 4 different cases from 4 societies, and I welcome all the societies, Patna, Lucknow, Ahmedabad, and Coimbatore for having very willingly obliged to be part of this wonderful seminar. I thank Mandakini ma'am. She's a past ICOG chairperson. Madam, so much. Thank you so much. I know you're extremely busy and I really wish you all the very best. And thanks so much for having spent this afternoon. Madam has another meeting at 3 o'clock. Thank you so much, Madam, for having come. Dr. Alpesh Gandhi is right now in the cesarean section. He said as soon as the case is over, he would try to join us. And I also thank, Madam is the chief guest for today's session. I welcome the guest of honor, Ramni Devi Madam. Dr. Basa Mukherjee, sir, he also said he's very busy. I think today everybody is busy with various meetings. Yeah. And Sampath Kumari, Madam said she will join at some time. She's right now in Tirunelveli attending another meeting. So all of them will try to join at some time or other. And my sincere thanks and welcome to Dr. Paili sir. In fact, all of us know that Paili sir does a lot of work in this confidential inquiry about maternal deaths. Sir was also very busy. He also had another meeting. So he said, I will ask Dr. Reshmi to join instead. And I'm, because she's also working with sir and then doing a lot of inquiry. I welcome Dr. Reshmi. And I welcome all the societies, all the 4 societies, Supriya Madam, Vinita Madam, Nisha Madam, and Yashodhar Pradeep Madam, and Dr. Munjal, and Dr. Munjal Pandey, and Dr. Jignesh. So I welcome all of them for having agreed to be part of this meeting. I welcome all the delegates who have logged in for this wonderful conference. Hope you're going to have a very nice time this evening. over to Dr. Baburani, who is the Honorary Secretary of COGS, who will be telling us about, who will be doing the MC for today. Dr. Baburani, take over, please.
Thank you very much, madam. The topic near miss is very, very important as they teach us unforgettable lessons or points of practice and make us stronger. Many a times this is not discussed publicly and openly. So today's meeting will give us very fine points for everybody who listens and who participates. I am glad to introduce Dr. Ramya, who is our treasurer of Coimbatore OG Society. She is a professor and head of the unit at the ONG department of PSG IMSR. As I said, she is the treasurer of our society. Her publications are national and international journals. Her special interests are in ultrasound and endogynecology. I invite Dr. Ramya madam to take the podium. Welcome, ma'am.
Thank you, ma'am. Good afternoon, everyone. I take great pleasure and privilege to introduce Dr. Mandakini Madam, our chief guest today. Madam is the past chairperson of ICOG from 2020 to 2021. She is also the International Vice President of Medical Women International Association, Central Asia, and Vice President of Association of Medical Women in India, Central Council. She has been the National Vice President of FOXI from 2012 to 2013. Madam has varied interest and also held many prestigious posts and has many awards to her credit. We request Madam to say a few words. Welcome, Madam.
Yeah. 1 minute. Am I audible?
Yes, ma'am.
Yes, Madam, you are audible, Madam.
So, good afternoon, a very good afternoon on a very busy day. Financial last day is there. And first of all, this is really a great pleasure. It's like coming back to the home, especially when we have Lucknow, where I was installed as the chairperson ICOG, Patna, Ahmedabad, and TNFOG. So, Chitra, thank you, great thank you to you, Dr. Baburani, Dr. Ramya, Dr. From the Trisur, Dr. Remy, representing our Dr. Paili, and my dear friend Ramni Devi. So it's very nice to be there. First of all, you're keeping this topic of near-miss is a very crucial and very important at this juncture. Especially we are all feeling the heat of a loss of a gold medalist doctor, of our fraternity, for such a frivolous lack of knowledge of that police person that he should not have lodged the FIR. This is so much, I mean, very saddening experience. And as Chitra has put very correctly, as a professional body, we must come together and do something very concrete for this, which I think is the need of the hour. So with this, I want to, I extend my warm greeting to guest of honor, Dr. Ramni Devi, Dr. Basa, Dr. Sampath Kumari, all the faculties who are busy, though they are very busy, but they are here to discuss such an important issue. As Dr. Chitra has mentioned, that near-miss cases are really require all your expertise, all your things, and where they come directly to the tertiary hospital. Where I was heading Kama Hospital, I have seen only near-miss cases. I can say I was expert in the near, because they are almost pulseless. PPH, abruptio placenta, obstetric hysterectomy. And I think a largest series of in Akola, Amravati, 9,000 to 11,000 cases, in which most of the cases were almost so severe. So I can correlate with these near-miss cases. And then what you require is a preventive measure. Why we are want our primary healthcare delivery system to be, to be taught to know the high-risk patients, to know the symptoms, and they could, prevent it at their level. That is what is the necessity of today. And primary healthcare system has to be strong, at least to identify. And once they identify, refer in time to the district hospital, so that all these cases can be prevented. From 17% to 31% as per WHO, we are having this near-miss, and almost 3 to 4% we are able to save it because we are working in the tertiary care. So friends, I think we are going to hear from experts. So many experts are there, and you are going to keep the discussion very, very lively, very useful, and very practical for the delegates. So Chitra, once again, I congratulate you.
Thank you, ma'am.
All of you, thank you very much for inviting me. And soon I am going to see you all in the cell. I am going to come for the conference. So thank you, Ramani, and thank you everyone.
Thank you, ma'am. Thank you, ma'am. Thank you so much. Doctor.
Madam, Dr. Alpesh Gandhi has joined in, madam.
Not yet.
So should we
We'll move on to Dr. Ramani Devi, madam.
So shall I introduce Dr. Reena, madam? Dr. Reena, madam, is also one of our professors of PhD IMSR. She has graduated from Kottayam Medical College and MD from Calicut Medical College with gold medal. I'm introducing Dr. Reena Abraham actually, who will be introducing Dr. Ramani Devi. Dr. Reena Abraham is one of our professors in PhD IMSR. She has graduated from Kottayam Medical College and MD from Calicut Medical College with gold medal. She is our honorary secretary of Covai OG Society, and she is a postgraduate and undergraduate teacher and examiner. Her special interests are in endogynecology and obstetric sonography. Welcome, Dr. Reena. You take over the podium, please.
Ramya, is Reena come there? Is Reena there? Reena?
Probably she didn't know that Dr. Manonmani is
Ramya,
not
you can.
Yes, madam.
Yeah, you continue.
So we welcome Dr. Ramani Devi, madam, to our webinar. Madam is the Managing Director of Ramakrishna Medical Center and Janani Fertility Center. She has won several gold medals and also prizes and awards. And she has been Women of the Year by the Bharathidasan University in 2013, and also Women Achiever Award by Citizens of Trichy 2015, and also Dr. APJ Abdul Kalam Award in 2016, to name a few. So Madam is a patron for Tamil Nadu Federation of Obstetrics and Gynecology Society. So we welcome Madam as a guest of honor. Welcome, Madam.
Thank you for the kind introduction. First of all, let me say thanks to the all the President, Secretary and members of Coimbatore Society, Patna, Ahmedabad, Lucknow societies for this very, very important webinar. And my special thanks goes to Dr. Chitra for having invited me as a guest of honor. And first of all, it's really sad that we have lost one of the very pioneers in the field of ObGyn, Dr. Archana Sharma. But I think the simple thing here now falls our duty to educate ourselves that how we should react in such times of crisis, because losing such a life is both for the community as well as the personal life. So we need to educate, empower our own self. That is how we should react in this situations, crisis situation. There should be a need for calling all the rush team so that we will have at least some sort of moral support. And again, there should be a licensing between the police department. And I feel this suggestion was given much earlier that we must put laws regarding when FIR should not be filed, when it should be filed in the OPDs of our own hospitals, so that the police will also understand, and we need to educate the local police team as well as you should have a good rapport between the local higher officials of the police. Anyway, my pranams and respect to the departed soul. Next, coming to this particular topic of maternal morbidity, like Chitra had said, it is around 1 in 25. Earlier, we used to say the incidence of maternal morbidity is somewhere between 1 in 200 of every mortality. But now, India or globally, there is reduction in the maternal mortality from what it was earlier, and especially in Tamil Nadu, it has come down to 60s. We have achieved something, but still it is not up to the required number of 30. But otherwise, the morbidity what we are seeing, secondary to this complications what we meet within the pregnancy, that has to be dealt with in detail, because this can be causing permanent disability to the couple, or permanent disability to the woman. So the most important things, the cases that you are planned today are acute fatty liver of pregnancy, though it is uncommon. It is a very, very grave one, and we have to actually pull the patient from the hands of death. Again, disseminated intravascular coagulation is another common condition which we see increasing incidence in hypertensive disorders complicated pregnancy, and viral hepatitis C, though not commonly seen, we do come across cases which are tend to be fatal. And the last one, that is a septic abortion. Septic abortion with multivariant complications like gut injury, bladder injury. All those things we have seen it in years in the government medical college setups. But now, because of the awareness among the medical termination, which is legalized, and the respectful abortion care, the training that is being given to the doctors and the paramedical people, I think we can comfort to some extent the septic abortion and the sequelae. So now we have very excellent speakers like senior people like Dr. Bailey, who has been working mainly in this particular field of reducing the maternal morbidity, I think, and all the speakers, chairpersons are very eminent people who are learned and who have great experience. This webinar should be a great one. I congratulate the Coimbatore Society, Lucknow, Allahabad, Patna Society for having arranged this important webinar on a very, very important topic. And thanks for the opportunity given, and all those who are going to contest for the chat. Thank you.
Thank you, madam. Thank you for that very encouraging words. Now we would like to welcome Professor Dr. S. Sampath Kumari, madam.
Ramya, they're
Yes,
not there, so just straight away go and introduce Dr. Reshmi, and then we'll move on to the first session. I think Dr. Reshmi is already joined. You just introduce her, because all the others will just join.
Yes, Baburani, madam.
Yes, I am coming in.
Yes, madam.
Dr. Reshmi is a nodal officer, M&M Review, Kerala. She has worked closely with Professor V.P. Paili, and probably their main aim is to look at how to reduce morbidities in women who are going through pregnancies and deliveries. She had been awarded gold medal for best outgoing PG in 2002 itself, and she received chairman's gold medal from Dakshin Quiz in 2001. Her areas of interest is quality improvement in healthcare, which is very mandatory. The line of thinking itself is very mandatory, and she is also interested in high-risk obstetrics. I welcome you, madam.
Thank you. Thank you, madam.
Thank you, Reshmi. Welcome, Reshmi.
Yes. Dr. Paili couldn't join. He said he will try to join if possible. He's busy at present, busy.
Yeah, he told me, he said he will try to join. Okay.
Okay. Thank you, ma'am. Thank you for the invite.
Now, so thanks to Mandakini madam and Ramya madam for having spent their valuable time. I know both of them are extremely busy, and for all the well wishes for Supriya madam and for me for the coming elections. And wishing you all the very best, ma'am, Mandakini madam and Ramya madam, for your forthcoming elections next year. With this introduction, we'll move on to the main sessions. I request Baburani to start the session and introduce the chairpersons.
Dr. Ramya is already known to you.
Yeah.
She will be introducing the chairpersons, Dr. Supriya Jaiswal and Dr. Vinita Singh from Patna Society. And we are very glad to welcome Patna Society for taking part with us. I'm handing over to Dr. Ramya to start introducing. Thank you.
So we will be starting the first session from Patna OG Society. I would like to welcome the chairpersons, Dr. Vinita Singh, who is the president of Patna Obstetrics and Gynecological Society. Madam is the associate professor, Department of ObGyn, NMCH Patna, and consultant at Care Hospital and IVF Center. Madam has many posts, prestigious posts, and has attended many conferences and workshops and organized it. Madam has also won many awards. We welcome you, Madam. We would also like to welcome Dr. Supriya Jaiswal, Madam, as the chairperson. She is the secretary of Patna ObGyn Society and chief consultant at SM Hospital, Patna. She also is a specialist at the government hospital and her special interests are in high-risk pregnancy and preventive oncology. We welcome you both, ma'am, and you can take over the podium.
Thank you very much. At the outset, I would like to thank the Coimbatore Society, especially Dr. Chitra Madam, for arranging such a wonderful webinar today on this last day of March. So I also thank all the societies, the Ahmedabad, Lucknow, our society and Tamil Nadu. So all the societies together had made a very program webinar on a very important subject, that is near miss case discussions. I think a lot of gynecologists, and very unfortunate for us, like we had recently lost one of our colleague, junior colleague, that everybody knows due to this obstetric complications. So moving ahead, I would like to just extend to you the deep apologies from Dr. Vinita Singh, President Patna Society. She has an emergency in the medical college today, so she will try to join later. But till then, I'll be taking over the session. So my presenter is Dr. Monica Anand. So can I have the CV? So she will be talking on placenta accreta. One sec, madam. Placenta accreta with acute abdomen from our society. So Dr. Monica Anand, she is additional professor in Department of Obstetrics and Gynecology, AIIMS Patna, All India Institute of Medical Science in Patna. She has been a brilliant student and she's been authored 2 books, contributed 4 chapters in textbooks. She has got many publications, more than 35 research papers in indexed national and international journals. She's also the peer reviewer in BMJ case reports, Archives, Gynecology and Obstetrics, GOG Research Cancer Reports, state level resource person for MIYCN training, and then clinical secretary Patna OBGY Society, co-chairperson Urogynecology Committee, and she keeps real special interest in endoscopy, gyne oncology, and high-risk pregnancy. So she's taking over this high-risk pregnancy case. And I think, so Monica, over to you for your case presentation.
Thank you, Supriya ma'am, for your kind words. First of all, I would like, at the outset, I would like to thank the Coimbatore Society, Chitra ma'am, Baburani ma'am, Ramya ma'am, for organizing this wonderful webinar on near miss cases, which is now the talk of the town, and we need to learn from each other. That is the main point of this webinar. And my best wishes to and pranam to Mandakini ma'am and Ramni Devi ma'am for her upcoming elections. And with this, I would start with my presentation, which is actually on a placenta accreta case in a 2nd trimester. Can I share my screen, please? I hope it is visible.
Yes, it is.
Yes, you'll have to make it full screen.
I'm doing it, ma'am.
Yeah.
So this was a placenta accreta with an acute abdomen in the 2nd trimester. This patient actually presented with the chief complaint of retention of urine and weakness and severe pain abdomen for 4 days. She was a 41-year-old, gravida 3, para 2, living 2, and abortion nil. At period of gestation 26 weeks 1 day. She came to the labor room emergency with an in situ IV cannula and urinary catheter. She had, because of retention of urine and mild pain, she was admitted in a local hospital where she was transfused 4 units of fluid and was catheterized. She denied any intervention she underwent for abortion in this last week. She was actually an unbooked case, had done an UPT at home. Her first and second trimester histories were normal with no history of bleeding, PV, leaking, headache, vomiting, or blurring of vision. She had an ultrasound report of 22 weeks gestation, which reported the placenta as fundo anterior. She was a twice cesarean section, with the first cesarean section done in 2017 for a breech presentation and into 2020 for an impending rupture. And this pregnancy was within 9 months of the previous cesarean section. She did not have any past significant medical or surgical history. On the examination, we found that she was conscious, alert, cooperative. She was afebrile. She had severe degree of pallor with no edema, cyanosis, or icterus present. She mostly presented in a condition of hemorrhagic shock with a pulse rate of 110, respiratory rate 22, BP of 80-50, and saturation maintaining on room air at 96. Chest was bilaterally clear, and the CVS examination was normal. On per abdomen, we found that the abdomen was tense and tender, mostly on the left side more than the right side. And the uterus could be palpable, the contours could be felt, and there were no contractions. The tone of the uterus was not increased. FHS could be found on auscultation. Bleeding PV was not present, os was closed, and cervix was long. In the labor room, we performed an ultrasound to detect the cause for the tense tender abdomen, and we could find around a 500 grams baby with fetal cardiac activity present. There was clot present along the left side, and the placenta was seen to be in the lower segment, although the previous report had reported it as in the upper segment. The ultrasound was then confirmed from the radiology department after the initial resuscitative measures, and it suggested a diagnosis of uterine rupture with a collection on the left side of the pelvis, which was mostly organized, and a live fetus of 560 grams was confirmed. So with this history and examination, we came to the differential diagnosis of either a ruptured uterus, but here the uterine contour was normal, FHS was present, there was no history of bleeding PV or hematuria, neither any intervention from outside. Might have been an abruptio placenta also, but the tone was not increased, and the uterus in itself was not tender. Fetal heart rate was present, BP was low to normal, but this can be there if the patient is presenting in shock. Any pelvic vessel or extrapelvic vessel rupture or splenic rupture was ruled out by ultrasound. The patient, the other differential was a peritonitis, but the patient was afebrile. She did not have any guarding or rigidity, and only a localized tenderness was present. There was no history of any abdominal trauma, and a pelvic mass could have been a differential as well, that could have caused retention of urine due to pressure or pain due to torsion, but it was not seen in any of the ultrasounds that we did. So the initial investigations on management gave us a picture of a hemoglobin of 4.6, platelets normal, TLC of 7,000, coagulation profile was normal. LFT and KFT were in the normal ranges. Patient was non-reactive in HIV and HBS. So the initial management that we did was to give a fluid bolus of 125 ml with 2 large IV cannulas. She was already catheterized, so we monitored the vitals and the urine output, arranged. In the meantime, the blood and blood component arrangement was done from the blood bank. ICU availability, neonatologist availability, and the multi-specialty team availability was ascertained. And then a high-risk consent was taken from the patient for the present clinical status, for the operation, and proposed, if required, a hysterectomy, because at that time we were thinking of a ruptured uterus. On laparotomy, what we found, the laparotomy was taken under a general anesthesia with proper evaluation and invasive monitoring of the patient with 1 arterial line and 1 central line and 2 venous cannulas. Compression stockings were applied intraoperatively with the opening of the abdomen after full asepsis. Midline intraumbilical incision was given. We found 1.5 liters of flocculated blood collection to the left side of the uterus, which was localized and had septation. So it was scooped out from the left side, and the uterus was exteriorized. We did not see any rent on the uterus, but we found adhesion of omentum on the uterus, and there was a small area in the lower segment which was having an exposed area of placenta with multiple vessels running and very thinned out lower segment. So this area which was exposed on the right side was approximately 1 × 1 centimeter. At that present time, there was no active bleeding from that side. Most likely the placental vessel at that place had thrombosed. We also assessed the whole abdomen for any other sources of bleeding which might be present, because no uterine rent or bleeding from the uterus at that present moment was found. So liver, spleen, the bowel, mesentery, all vessels were checked, but no bleeding sites could be confirmed. With now we were confirmed that the placenta, since it was extending till the bladder serosa, is a case of placenta percreta, and we need to move forward with a cesarean or a peripartum hysterectomy. So a transfundal or a classical cesarean incision was given on the uterus on the fundal region to deliver a fetus, which by that time was 570 but was stillborn. And since there was placenta previa on incision, we found the lower edge. We tried to tug gently on the umbilical cord, but the placenta was not ready to give way. So now we did not attempt to remove the placenta, left it in situ in the uterus, and a supracervical hysterectomy was done because it was impossible to reach below into the cervix. Upon dissection of the bladder from the uterus, there was massive bleeding, around 1000 ml of fresh bleeding, and that also resulted in a rent of 2 × 2 centimeter on the dome of the bladder, which was repaired in 2 layers, and hemostasis was secured all over. All the raw areas were examined, and after that bilateral uterine internal iliac artery ligations were done. Drain was given and the abdomen was closed in layers. This was the post pictures of the uterus which was removed. So placenta was in situ, and the lower segment shows that the placenta was completely involving the lower segment, and the internal the myometrium was very thinned out, and there was no space between the myometrium and the placenta. So in the OT, because of 2 units of blood transfusion and almost 2.5 liters of fluid transfusion within 1.5 hours the OT lasted, the pulse and the BP was maintained, and the MAP was maintained above 60. Urine output was also maintained 40 to 50 ml per hour. Drain output at the end of OT was just 25 ml, but it increased later on. And by that end of the OT, the patient could be extubated, and then she was sent to the ICU. In the ICU on day 1, the pulse rate was on the higher side of 104 to 96, BP on the lower side of 84 and 52. Initially, the MAP was 52, but on fluid and blood resuscitation, the mean arterial pressure rose to 68 to 70 on the first day. Saturation was maintained on 10 liters oxygen for the first few hours, and then on 5 liters. GCS was 15, random sugar monitorings was normal. IV fluid in the whole was given as 2365 ml with blood products of 2 unit blood, 2 unit FFP, and 2 units platelet in the 1:1:1 transfusion protocol, and urine output was maintained. Patient was put on NPO. She had a slight abdominal distension with sluggish bowel sounds. Low molecular weight heparin was started post-operatively after 12 hours with IV antibiotics, tranexamic acid, and other supportive medications, and catheter was decided to be kept for 21 days. After the OT procedure, the hemoglobin fell to 3.7 for 4.6, but after 2 blood transfusion, it again rose to 6.3. Platelets, TLC, LFT, KFT were normal range. Lactate rose to 1.8. The patient already also had an episode of pulmonary edema, which responded to 2 doses of furosemide, although no ventilator support was required. On the second day, the patient was better with a hemoglobin of 6.3, where again 2 units of PRBC were transfused to take up the hemoglobin to 7.8. Rest of the investigations were normal, and the lactate decreased to 0.8. The BP also rose. MAP was persisting at 65 to 76. Saturation was maintained. Oxygen was now reduced to 2 liters. The patient was fully conscious with a GCS of 15. RBS was normal. We started with liquid diet on the second day, and the intake output were normal. So we coming to the drain output, we had a problem with the drain because on the post-operative day 1, the patient had approximately 845 ml of hemorrhagic blood. On POD2, again 1150, which was a huge amount. And this led to again a fall of hemoglobin. And then we transfused 1 unit of BT again. Frank blood of 120 ml came on POD5, which later turned to serosanguinous and decreased subsequently to 25 ml by day 1250, on which The drain was then removed after 3 days of successive 25 ml of drain output. The catheter care required was also a little bit stormy during the post-operative period. In the initial time, the urine was adequate and clear, but on day 13, there was a frank hemorrhagic urine, which led us to believe that maybe the bladder repair has given way and the bladder has ruptured again. So a USG and a CT scan was done, which I will discuss. The report suggested a WBC count, but the RBC was only 6 to 7. Urologist consultation said that only a saline gentle wash should be done with 100 ml with vitamin C and solifenacin to be started from day 14. This hemorrhagic urine turned to yellowish white pus on day 16-17, for which the urine culture reports came as positive and appropriate antibiotics were then started. And it turned to hemorrhagic and clear on day 21-22, and on day 23, the catheter could be removed and the patient passed urine comfortably. So the whole post-operative course was the patient was tolerating oral feeds, was well and passed stools on post-operative day 8. On day 10, she had a temperature rise of 102 to 101 degree 8 hourly. It lasted for 72 hours, for which all the investigations were within normal limit. But the ultrasound showed a pelvic echogenic collection with separations of 50 ml, so which was most likely the cause for fever. And on POD 13, we did a CECT on the day that we had hemorrhagic urine from the catheter, but the bladder walls were found to be intact, and there was only a mild pelvic collection which was organized at the stump. On day 14, a repeat urine culture showed a positive report for which antibiotics were reviewed. Abdominal wound sutures were removed, only a mild discharge was present, but the skin had healed nicely. POD 15, we removed the drain. On 16 to 20, she complained of mild vaginal discharge, which was blood mixed, but on per speculum, the vault was intact and not much of finding was there. On day 23, the urinary catheter was removed and the patient was then discharged. So the morbidities that the case of placenta percreta was found in this case was she was already presenting in hemorrhagic shock. We had to transfuse 7 units of PRBC, 4 units FFP, and 4 units of platelet. There was bladder injury during the procedure of the hysterectomy that we attempted. Fetal loss, obviously, because the baby was more or less non-viable. And there was ICU stay of 48 hours, but no ventilator support was required. After a week, the patient was followed up. She was having normal bowel bladder function and no complaints, no vaginal discharge or at present. And also after a month, we did an ultrasound to see the pelvis collection had organized and now no complaints were present. So to summarize, she was a gravida 3, para 2, living 2, repeat cesarean section with an interval of less than 1 year from the previous section. She presented with with retention of urine and abdominal pain, but having features of acute abdomen. We initially thought of a diagnosis of rupture uterus. Laparotomy revealed a hemoperitoneum with placenta percreta of grade 3A according to the FIGO grading, for which an obstetric hysterectomy was done with internal iliac ligation and bladder repair. The patient required 7 units blood, 4 units FFP and platelets. She had a 2-day course in ICU and a total 23 days of hospital stay, after which she was discharged in a healthy condition. Thank you.
So, thank you very much, Dr. Monica. Actually, it was a real well-presented case and a real near miss. So, what do you think? What was the main point you got? So, what was to be missed and you handled the case? What was the main point? Can you?
Ma'am, actually, when we opened the abdomen, we could not, because it was an emergency case. So an emergency ultrasound was done. We could see that there was placenta previa, but it did not click to us at that point that it might have been placenta accreta because the patient was already having 2 times cesarean section. We know that with cesarean section and placenta previa, the risks of placenta percreta increases exponentially with the number of cesarean sections. But at that time, it did not click. So we opened the case because of hemoperitoneum, but we were surprised because there was no active bleeding from anywhere. Although the placenta had, like it was poking from the lower segment, but at that time there was no bleeding because the patient was sick from last 7 days. She had a little bit of bleeding, continuous bleeding, and that had stopped. So doing a proper ultrasound in a post-CS pregnancy is the most important thing, I think. And doing it yourself, like for any post-CS pregnancy who is having a lower placenta, especially a lower placenta, is of utmost importance to diagnose a case of placenta accreta spectrum. So, and that is also recommended between 18 to 24 weeks. That is the best time to detect placenta accreta spectrum. So that is the one thing we have to keep in mind, all the risk factors, whether the patient has any risk factor for placenta accreta or not, like a post-cesarean, a placenta previa, any history of previous uterine surgeries, like Asherman syndrome or a myomectomy or a DNC, or maybe having any infections like that. So if we have those risk factors in mind and do a proper antenatal diagnosis of the case, then we would be able to manage the case much better in a planned hysterectomy, because the recommended approach is to do a planned hysterectomy, cesarean hysterectomy at 34 to 35 weeks of gestation.
Yeah, there was also a case, usually the ultrasound showed all the time increased vascular channels, but they never said it was a accreta case of, but
Yes.
that was also a case where we found this percreta on opening. So
Yes.
same way that like you got the case after laparotomy, so it happens. This is real a near miss, and it is a it is a nightmare for the obstetricians. A good unit like you people, like in the All India Institute, you have all the facilities, so you can manage in every way. And what are the recommended managements of PAS?
Ma'am, for recommendation, like first of all, we have to know the risk factors. We have to make an antenatal diagnosis that gives us the best outcomes in case of morbidity and mortality, less amount of blood transfusion, less amount of ICU care, less long-term morbidity. So if we have diagnosed a case and she is asymptomatic, so we can plan for delivery in a level 3 tertiary care where all blood bank facility, anesthesia, ICU care is available with a proper team at 34 weeks gestation, because it is no benefit of keeping the patient till 37 weeks if she goes in early labor. An emergency section and emergency conditions will lead to her morbidity more than an elective and a planned surgery at a proper time when every facility is available. So that is the management with complete backup of blood bank with massive blood transfusion protocols in mind. And there are other conservative managements also, but they have to only be given to very well counseled women who have been extensively counseled about the risks of later on morbidities, because those who undergo conservative surgeries, they have a very high morbidity of sepsis or repeated bleeding, or even again risk of hysterectomy. So there are few modalities which are there for conservative management, like we can intentionally keep the placenta inside and then wait for the spontaneous resorption of the placenta. But it has been seen that it takes a very long time. There is continuous bleeding, there is risk of infection, sepsis, and again, cases of hysterectomy and death has also been there. So, and it takes approximately 13 to 15 weeks for that placenta to resorb. Methotrexate is now not at all recommended because it has no evidence of placental resorption. It leads to renal toxicity, hepatic toxicities. It is contraindicated in breastfeeding. So we cannot give methotrexate. We just have to wait and watch with proper follow-up, which is not always possible for patients. Also, there are other procedures like we can just do a focal resection of, if there is some focal placental accretal adhesion, then from there we can remove the myometrium and then repair the uterus. That can be done. Or there are triple P procedures which are very popular. That is also based on similar this thing. That part of the uterus needs to be perioperative localization of the placental edge has to be seen. An incision above that area has to be given to deliver the baby. And then the placenta can be kept in situ, and you have to have a radiological support where the interventionist will give a interiliac aortic balloon there so that the bleeding can be stopped and then the uterus can be repaired with excision. So there are few cases, but there have been many cases, but with these conservative management, the morbidity also increases very much.
So what do you think is the cause of severe acute maternal morbidity usually? One of the main causes.
Ma'am, for our developing country, mostly it is obstetric hemorrhage, number one, and then comes preeclampsia, all the complications of preeclampsia. obstructed labor, sepsis, which we will be discussing also, I think. And these are the main conditions. And severe anemia in our, which is prevalent, like anemic mothers landing up in pregnancy.
So really very well discussed, well managed. This case you have presented very well, Dr. Monica. So a few take home messages. What I think, the diagnosis of antenatal period, dedicated ultrasound for placenta in women with high risk like previous one cesarean, management of PAS by dedicated multidisciplinary teams, as you said, is associated with lower composite scores of morbidity. Then lower incidence of massive transfusion, fewer reoperations for bleeding complications. It's very bad to reoperate. Actually, it feels very nasty once you have to reopen the case, no? So management of obstetric hemorrhages in high volume tertiary care setting is also associated with lower maternity center, which we should be very careful, and we should always make sure that we have got all arrangements or high definition units so that we can well manage. We shouldn't take in a small place such complicated cases. So we should be very aware of this. Very well presented, Dr. Monica. So we end the case here. Thank you very much.
Thank you very much, Monica and Dr. Supriya ma'am. And I just want to ask Dr. Reshma, because we also see a lot of cases like placenta previa, and just like how we have done, we've also had bladder injuries. I think in Kerala they do certain different techniques. So maybe Dr. Reshmi could throw some light on it.
Thank you, Dr. Chitra. Exactly, that was what I wanted to convey. Here, when we started the maternal near-miss review.
Louder, Reshmi.
Yeah, 1 second. I think there is some problem. Okay. Now, am I audible?
Yeah, better.
It is better. 1 second. Please wait. Now it should be okay. So when we started our maternal near-miss review in 2017, we were not sure what would be the common causes which would come up. But we were, as Dr. Monica said, we were expecting hemorrhage as the most leading cause. But so it was actually after 2 years of maternal near-miss review, when we analyzed the data, we found that the category 1. So I'm sure all of you must have gone through the Government of India guideline, operational guideline. So category 1 near miss was the most common. 93% of the cases, 93% of the cases were belonging to category 1. That is a pregnancy specific. And of them, majority were due to hemorrhage. And of them, majority, more than 50% were due to placenta accreta, closely followed by atonic PPH and traumatic PPH. So that made us again make sure, because when we analyze the maternal mortality data, for every 2 maternal deaths which occurred, we had 37 cases of maternal death which occurred due to placenta accreta. We had 37 cases of placenta accreta, which we could say. So then we analyzed what was correct. Actually, when we analyze maternal near-miss review, the whole purpose is there are 5 points we have to take in consideration. The first would be to identify the cause of maternal near-miss, then to identify the health system response, how the health system, because Dr. Monica, I should say, it was a wonderfully managed case. Actually, you could save the patient at 29 weeks, because 29 weeks, we don't usually expect a placenta accreta.
26.
26, very early. Yeah. So it was actually a wonderfully managed case, apt decision for laparotomy and a quick response. The whole team must have worked in a very, systematic way to save that patient. That's how we save the patient. And again, the third purpose is to identify the gaps in delay, the delay in seeking care, delay in reaching the facility, or delay in the, starting the care. So and also, we give regular feedbacks and identify which were the factors which saved this patient. One patient lost her life, but another patient was saved. So what were the positive things which saved the patient? That was what we started analyzing. So first, our pilot study was in all 5 government medical colleges. So we found that the the places where we anticipated, did a preoperative DJ stenting and arranged enough blood, and also used the aortic clamp. I'm sure you all might have heard about Dr. Piley's aorta clamp. It was earlier used as a common iliac clamp. Then we started applying as a aorta clamp. Earlier we used to put in tourniquets, but once the aorta clamp was introduced, we started using it. One college started using it, and in that college, most of the patients required one third of blood transfusion. There are the other colleges which had this ejaculate. So many of the government colleges started using the aorta clamp. We have elective cesarean section at 32 to 34 weeks. DJ stenting was done, and we regularly started using the aorta clamp. And that turned the tide in favor of the mothers. That's what we found. Okay. And it was wonderful that you could, with 7 units of blood and blood products, obstetric hysterectomy, even though we could save the mother's life. That is what is important.
Thank you, Dr. Reshmi. Now, could we go on to Lucknow Society now that Yashodhara Madam is there and she would like to leave by 4? Can we have your presentation, ma'am? Shilpa? I think yes. Shilpa is there. Yeah. Shilpa, are you there? Yeah. Supreme, thank you so much, ma'am.
Thank you, ma'am. Thank you for the opportunity.
Dr. Chitra, I will not be able to continue this because I have to have my institutional meeting at 3. So probably Nisha is going to come at 3:30 or something, Shilpa?
Yes, ma'am. My ma'am will be free by 3:30.
3:30. So I suppose you text her that she should come at the 3rd case. And second case, let the second case finish. And the 3rd case, because I have to join my institutional meeting at 3.
Madam, because Dr. Nisha said she's not coming, we'll just go ahead and finish yours, madam. Shilpa, we will just comment if it's not possible. She will finish in 10 minutes.
Okay.
Shilpa, yeah.
Chalo, okay. Because so much is happening because of Dr. Archana Sharma's case. And yes, it's really very tragic also. It's very tragic. Yes. Yes. So I thought that we must unite and we must go, and plus this is an institution meeting also. So what you can sacrifice the academic program because they keep on happening. Institution meeting not in your hand, and this protest march is also not in your hand. But that is a must. Protest is must.
So we'll forego the introductions.
Yeah. Yeah, of course you can forego because we know each other.
Yeah, we know each other. So
I just want to add, in the previous case, as Dr. Reshmi has said, it is not diagnosed before 29 weeks. I have operated at 20 weeks the placenta percreta. She was admitted to me with the hematuria. So she was referred to urologist from the gynecologist, and the urologist referred it to me because he asked to get an MRI done for the hematuria, which was not responding by the gynecologist treatment. And so he has the urologist, not the gynecologist, it is the urologist who has referred to me. And you cannot believe how I could save that woman. There's no time, so I just cannot do this. So at next time, we should have various presentation of one type of the case. That will give you much better scenario. Okay, thank you so much.
Ma'am, I'm not able to share the screen. Yeah, now it is coming. The option is coming now. Just a minute.
Chase?
Yeah, ma'am, just a minute.
But tech people, can you help?
Yes, ma'am.
Yeah. Shahiti, please help her, no?
शिल्पा 15 मिनट में खत्म करना होगा क्योंकि मैं 3:30 पे निकल जाऊंगी उसके लिए, और कम से कम 15 मिनट में इंस्टीट्यूट की मीटिंग अटेंड करूंगी.
Yeah. It is a short presentation.
It's a short case.
Yes.
Okay. Go ahead,
I'm Dr. Shilpa.
Shilpa.
I'm associate professor in KGMU. Today I'm going to present the maternal near-miss case.
Well, louder, Shilpa. Yes, Shilpa, please, louder.
Okay.
Louder.
You come to near to mic of your laptop or whatever the device you are joined, and increase the volume of your audio setting.
slide is not moving actually. Yeah. Okay, so this patient has come to us as a case of 28-year-old, the third gravida, unbooked patient. She had history of 4-month amelia in a private clinic by a nurse. On day 3, she developed abdominal pain and abdominal distension with a history of 2 days. And then she went to the private where she had her DNC. From there she was referred to KGMC. On admission, her blood pressure was 126 by
15 hours.
Slight tachycardia, tachypnea, and patient was febrile. She was moderately anemic with a TLC of 22,000. Her LFT was normal, but KFT was deranged. On per speculum examination, we found a loop of intestine coming out of the os, and on per abdominal examination, there was a generalized distension and tenderness present. So our provisional diagnosis was a case of septic abortion post DNC with bowel injury. The patient was immediately taken for emergency laparotomy. In that, we found a uterine perforation in posterior wall of around 3 centimeters, and there was a ileal perforation 3 feet proximal to the ileocecal junction. The patient was, the primary uterine closure was done and double barrel ileostomy was done. Peritoneal lavage was done, followed by drain insertion. The patient was only on day 7 and abdominal drain was moved. On post-operative day 8, she developed deep surgical site infection. The patient, that was managed by laparoscopy with CELO application and end mask closure. On post-op day 18, patient was discharged with stable vitals. So this is the per-op picture of showing the perforation and the gangrenous bowel. So what are the maternal near-miss events in this case? We all know that for maternal near-miss diagnosis, we need one each of the following criteria: symptom, sign, investigation, and intervention. So she presented to us with abdominal pain, distension with guarding and rigidity. Her pulse rate was greater than 120, respiratory rate was greater than 20, TLC was greater than 15,000. On X-ray, erect abdomen, there was gas under diaphragm. The patient was managed by laparotomy with bowel repair. There was a need for ICU admission and the need to administer 4th-generation antibiotics. For coming to the discussion, for every woman who dies from pregnancy or childbirth-related causes, 20 more suffer from pregnancy-related illness or severe complications that are categorized as near-miss. Unsafe abortion contributes to 8% of maternal mortality ratio in India. Incidence of unsafe abortion in India is 0.4 to 15 per 1,000 abortions. Induced abortion, as we all know, can be done medically or surgically. Surgical abortion, if done by untrained hands or sometimes by most experienced person can lead to hemorrhage, infection, uterine perforation, and rarely bowel or bladder injury. The predisposing factors to uterine perforation are increased maternal age, greater parity, advanced gestational age, history of previous cesarean, and the uterine attitude. That is, if the uterus is acutely retroverted or anteverted, there are more chances of perforation. When bowel injury is recognized, the patient should be immediately taken for laparotomy. In septic, it has been found that in septic abortion leading to bowel injury, ileum is the most commonly involved in such cases. Uterine fundus is most common site of injury. The most commonly performed surgical procedure, if recognized in time, is resection and anastomosis. So when we, in such cases, when we find that that there is a case of septic abortion with bowel injury, and the patient presents to us within 24 hours with localized peritonitis, mild enteritis, and single perforation, she can be managed by primary closure. If she presents within 24 hours with mild to moderate enteritis and multiple perforation and areas of impending perforation, she should be managed by resection and anastomosis. Ileostomy, like in our case, is required when the patient presents greater than 24 hours after perforation and she is hemodynamically unstable with generalized peritonitis, severe enteritis, multiple perforation, and areas of impending perforation. The key to a better prognosis is earlier complication identification, and if the patient is at some primary care center, she should be immediately transferred to a tertiary care center. To reduce the morbidity in such patients, we should ensure that there is a short stay at the hospital. Resection and anastomosis, if possible, should always be preferred to ileostomy, and appropriate supportive care. By appropriate supportive care, I mean the preventive steps which need to be taken, that is comprehensive sex education, unintended pregnancy prevention through effective contraception, and the provision of safe and legal abortion methods. There have been a number of cases previously reported in India of these. 2 cases were of omental prolapse, in which omentum was cut, clamped, and ligated. If we consider the site of injury in the bowel, the 4 cases were of gangrenous small bowel, and 4 cases were of mesenteric stripping. If we consider the presentation, in these cases, it is presented within 24 hours, 2 within 3 to 4 days, and 1 within 45 days after DNC. In our case, the patient presented with 4 months amenorrhea, and after 4 days of perforation with a gangrenous small bowel. The area of injury was fundus, and it was managed by double barrel ileostomy, while the uterus was managed by taking a suture. So the take home message I like to give in this case is bowel injury after surgical abortion requires timely recognition. Bowel can be saved by timely treatment and precludes the need for secondary laparoscopy closure surgery. Unsafe abortion practices need to be minimized by provision of respectful abortion care. Thank you. Yes, ma'am.
Thank you, Dr. Shilpa, for the very wonderful presentation. I think septic abortions, we don't see many septic abortions in our places, very, very rare. So, I mean, we've heard of this when I was a student, I used to say bowel injury, etc. But I really don't see any such cases now. Yashodhara ma'am, would you like to say your comments, ma'am?
Yes, Dr. Chitra, thank you so much. And best wishes to you and Supriya, and if anybody else is there who is going for the election, I really wish you all the best. This is the best thing. Case discussions are the best things, and you have chosen a very good topic. As far as it goes to septic abortion, there is a definite decrease in the septic abortion cases since the medical method of abortion has come, and little bit of awareness has also come. But I can say that these type of the cases is still occurring is really sad, because I have seen these kind of the cases in 1981 when I was 1982 when I was a house officer, and we saw this kind of in which a person has taken out the contents of the right area fossa. Can you believe that? And we had that patient for nearly 3 months in our hospital, and we had what not is being done to her to save her life. Of course, we saved. And the relative has given the red carpet and the rose bed treatment to the consultant who was under whom she was admitted. But see, the respectful abortion care is still the septic abortion, unsafe abortion, not the septic abortion, unsafe abortion, leading to septic abortion is still a third leading cause of maternal mortality in India. So it is not state-wise, it is all over India. It is the third leading cause of the maternal mortality, one thing. And as we have seen in this case, all 3 things were present. Neither the place was recognized, nor the instrument were there, and neither the person who was qualified. So it is a definite case of the unsafe abortion. I just want to have, because I have not seen anything, I did not had any questions with the Shilpa. So I will be allowed to ask few questions from Shilpa. Because Shilpa, I have got no history of this. Like she is being done in a private clinic by a nurse. So that means these healthcare workers who are not been trained in the surgical abortions. Surgical abortion, we just do not say that it should be done by anybody who is less than MBBS. And MBBS is also should be trained. There is when you do a respectful abortion care, there is a slides which says who can do up to 9 weeks, who can do up to 12 weeks, who can do up to 20 weeks, who can do beyond 24 weeks. So all guidelines are there. It's the duty of all of us to spread this to all, not only to the doctors, to the healthcare workers also, that this is what you are doing. So at least if they come to know that this has happened, might be there's some improvement. And plus, see, this woman, she is not aware of where to go at 4 months amenorrhea. So I still want to know whether she was really having the pregnancy, because most of the time we see these kind of the cases who are having amenorrhea because of any other cause, like the tubercular endometritis, or there's some other causes, and people think that she is pregnant, and this is a very hard uterus, because otherwise 4 months pregnancy, mostly the cervix is soft. So these kind of the things should not occur. So I do not know whether the ultrasound has shown any product of conception or not. In this case.
There no previous ultrasound was done in this case.
But it must have been done in our hospital.
Ma'am, before taking up the case?
Yes.
And there were no products of conception as such in
so
this.
It shows, because you just cannot have the perforation and the iliac injury without leaving some products of conception inside the uterus. So it shows this amenorrhea was not because of this, and the person even could not recognize, or she did not want because of the money. Also, they do not, because UPT is now available everywhere. It's easily available, 40 rupees, or you can charge 100 rupees or 150 rupees, and you can prove it that it is a pregnancy or it is not a pregnancy. Because these tough cervix, when you do, otherwise you are doing a fundal, because at the 4 weeks, the uterus is also not retroverted. It is almost straight. So it is not a posterior. It is only in the retroverted uterus you get a posterior perforations. So here the things are really bad. Chennai is a very literate state in comparison to the Uttar Pradesh. Tamil Nadu is much better. So I'll say maybe because of this, it is not happening there. But global picture, it's a third leading cause, this unsafe abortion. And we have seen this is a case of unsafe abortion because she could reach to the best institute of the Uttar Pradesh. So she could be saved. And because everything was done despite 4 days after the injury has occurred. Only thing what you have missed, Shilpa, I will say, the peritonitis you must have added into it in the diagnosis, because after 4 days, I just cannot think it off that she was not having the peritonitis. You said tenderness. You said tenderness was there, so tenderness is a sign of peritonitis only. Yeah. So it should have been come into the diagnosis. Into the diagnosis. Because we are in the institute. We should, if we are having the peritoneal tenderness, it means there is a peritonitis. Otherwise, there would not be any peritonitis, and there will not be any peritoneal tenderness. So a distension and tenderness and absent bowel sound, these are all signs of peritonitis. One thing. So only message I would like to share is unsafe abortion is a third leading cause of India. Still it is there. Maybe few states are having less and few states are having more, but it is a global scenario is like this. Global scenario means Indian scenario is like this, the national scenario. Second thing, that I am really sorry to see this case, because I have seen in 1982, then we used to see once in a while, but for last, probably I do not know how many years after this, it has come to Queen Mary's Hospital or King George Medical University. I do not know. But when I was there, it used to come in probably 1 in 2 years' time.
Ma'am, it is more frequent, ma'am.
It could not be. You can have an audit. It will not be in a year, you will not get more than 2 cases. I'm sure. I'm sure about it. Because this is the institute which takes all referral. It's a very, very famous institute of mine. I'm very proud of it because I am a graduate, postgraduate, and the faculty of the same medical college. So that's my alma mater. Third thing I would just like to say, we should spread the message to the public, to all the healthcare workers, that safe abortion is the best. Otherwise, she should have referred this patient and she would have come in 24 to 48 hours. She went to somebody else. The fourth referral she came to here, and she has lost 3 full days. So that's the very bad part of it. So we have to, it's our duty only to spread these messages. And fourth, I have already said that we should have added the peritonitis into this thing. Otherwise, this case, if would not have come to this tertiary care unit, she would not have been saved, and we would have been recording it as a maternal mortality. But as it has been said, if there is a one near miss case, there is a 20 mortality, 20 morbidities are there, and that's a very true. We do not think it of that if there is a prolonged illness, that is also a morbidity. If anybody is having pre-sepsis, it's a morbidity, which we just ignore, because the woman becomes all right within 1 week because of the 4th generation antibiotic. It should not be. So thank you so much, Dr. Chitra. If any of the comments anybody wants to give, I will be most welcome.
Just one comment, ma'am. I was wondering, nowadays there is no place for surgical evacuation at all, because after these medical evacuation has come, medical termination has come, all of us straight away going for the medical termination.
Yes.
So that's why maybe we're not seeing any case unless it's been done by a non-medical person, is what I feel.
Yes.
Maybe the other from Patna Society, the other Ahmedabad Society, Dr. Munchan has already joined. Would you like to answer? And Dr. Reshmi also, you've seen any cases, because we hardly see anything surgical.
Yes, I wanted to say this because I'm in a hurry also. So you're very right. I wanted to make this comment because if it would have been anybody who is a qualified practitioner, they would have done at least the cervical wipening with the mesoprost, which is available, and to these nurses, paramedics, ANMs, everybody it is available now because of as a PPH for the prevention of PPH, and they could have used and this dilated. So I'm saying that she was not at all pregnant. It must have been hard cervix, and so she could not understand. There's no product of conception. And I do not know how the bowel has come. Maybe it has not come immediately, that perforation. Gradually, when the bowel movement have occurred, so she did not put any sponge holder or something. Otherwise, the bowel comes only when you put a sponge holder for evacuating your uterus, and then you pull the bowel through your perforation or through the pouch of Douglas. But she said there's no vent in the pouch of Douglas. So I'm sure this bowel has come out after some time. It was not immediate. The perforation has occurred. She might have diagnosed or did not diagnose. I do not know what exactly has happened because a detailed history is not available here. And then gradually the bowel went into this uterine perforation, and with the peristalsis, it has gone out. I can think of it. So thank you so much. Otherwise, it would have been a pouch of Douglas. Most of the time, the bowels are coming out.
Thank you, ma'am. Reshmi, have you in your inquiry any such cases?
Okay, first of all, let me congratulate Shilpa. It was a very well-managed case and actually a very rare case. Nowadays, as Madam told, we don't see that much of septic abortion because of the respectful abortion care we have started practicing. But I was so happy to see that you categorized that near miss into category 1 and sepsis, and also you told how it became near miss, the 3 criteria. Actually, if we think about it, I think she will come under the single criteria also, the heart-shaped criteria also, because she had an emergency laparotomy for stabilizing her condition. And was she ventilated? I can't hear you, Shilpa.
Maybe you are muted, Shilpa.
Ma'am, yes, ma'am. Actually, she underwent the procedure under general anesthesia, and then she was ventilated in post-op, then later extubated.
Okay, so intubation of the patient and ventilation and mechanical ventilation itself will make a single criteria, and she would qualify as a near miss with single criteria. So that was very good. So whenever we see a near miss, whenever we categorize them, then we see, we see how they became near miss. miss and what was the points and what went wrong, and also what was the correct attitude. And in our near miss review also, surprisingly, after hemorrhage, it was not hypertension which was the second common cause. The sepsis came up as the second common cause of near miss cases. Hypertension came a close third, maybe because we have better management strategies for control of hypertension and control of eclampsia. And one more question I would like to ask, could you give a feedback to the referring institution? I mean, the place, because it is a sensitive area, because you may not be able to, I mean, they may not take it very nicely, but it would be nice. It would be very good, really good. Not in such cases as Yashodhara madam told, this must be an unqualified person who had done the procedure. So maybe we may not be able to have a direct approach, but in other cases of near miss, it would be really good if you could give a positive feedback, positive and also a non-blaming, no finger pointing feedback, so that when they do a refer or when they see another case, maybe the near miss even may be thwarted at that level itself. In this case, it may not be that sensitive because, I mean, they may not be that feasible also because of the particular situation. Here, I think the authorities have to intervene. There should be a sensible approach from the authorities, because we should definitely prevent a septic abortion, because such perforation happening, such unscientific practices maybe. So I think whenever we see a case of feedback, better, always better, and they feel good also to hear that we have saved the patient, and that is one point.
It was a preventable cause, and Shilpa, I would still say, just to learn it, that we can have still the serum beta HCG done. If we have not done the beta UPT at that time of the admission, still it will be, because it is a 15th day, maybe it has become negative, but as a record, we can still have it and see that whether she was a case of pregnancy or not. And not only Dr. Reshmi is one thing, unqualified. It was the place was not certified.
Yeah,
the person was not certified. Even the instrument was not certified. Method, everything was went. So it was a most preventable cause which could have been prevented if there was any qualified person or the state authorities. But it should be reported to the state authorities, to the CMO. So at least CMO can go to that place and report this. This case should be reported to CMO. It is just between me and Shilpa to have the good outcome of our state, improve the scenario of the pregnant women of our state. So Lucknow CMO should be reported this case. Or if the phone number or something is available of that staff nurse who has done it, should be given, as Dr. Reshmi has very rightly said, without non-blaming. And serum beta HCG, I'm sure you can do it. Because now our hospitals are having NHM and everything, I'm sure that it can be done. To prove it, first you do a UPT and then you do this. So we'll know that she was not a case of, because we did not know the age and everything, whether she was a case of ovarian insufficiency, but at least you can say that it is a case of pregnant or non-pregnant, because only those patients can have such kind of the perforations in which you do not get anything into the uterine cavity, and you will have the posterior wall perforation, and you will have the bowel perforation after some time through this. Thank you so much, Dr. Chitra. I just got busy with you. And
Thank you, ma'am.
Thank you.
Thank you so much, ma'am.
Let me
so nice of you that you could join, ma'am, in spite of being so busy.
Thank you so much. I just get carried away with the clinical cases.
Thank you, ma'am. Thank you, ma'am. Thank you, Shilpa, for the wonderful presentation.
Thank you, Reshmi. Thank you, Supriya. Thank you, everyone. Okay.
Can we move on to the next case, Baburani? Unmute yourself, Dr. Baburani. Yeah. Baburani, unmute. Mute.
Yeah. Shall we go to Ahmedabad Society, madam? I am very glad to invite Ahmedabad OG Society, Dr. Manjal Pandey and Dr. Jignesh Deriwala to come in. I request Dr. Reena or Dr. Chitra to introduce the chairpersons, please.
Yeah. Can I have the CV, please? Okay. Dr.
I think if you are running short, it's okay,
Yeah,
madam.
yeah.
If,
Okay, fine.
You want to, yeah. Thank you, ma'am.
Okay, yeah, thank you. Okay, can we have the presenter, Dr. Munchal, if you don't mind?
Yeah,
We are
ma'am.
skipping the presentation
Dr.
because
Gira,
of
yeah,
lack of
Dr.
time,
Gira Dabi, yeah, Dr. Gira Dabi is going to present the case. Dr. Gira.
Yes. Hello. Am I
Yes,
audible?
please. Yeah, you are audible and visible. Please start the presentation.
Okay.
Any problem, Gira?
I can't share the screen, ma'am.
You can't share.
Could you please click on share screen button at the bottom?
Yes, I'm thinking it.
And then click on share.
Yes, ma'am. It's not happening.
Just present. No, if it's not there, doesn't matter.
One second, ma'am.
Ma'am, could you please click on green color share screen button, ma'am?
Yes, I'm. One second.
Yes, ma'am.
Yes.
Super.
So my case is a case of hepatitis E and DIC. As we all know, hepatitis E is a very fatal condition, and it has 15 to 25% of mortality in third trimester of pregnancy. So my patient is a 23 years old Hindu female patient belonging to lower socioeconomic class and a housewife by occupation residing at People's Village. She was an emergency case and referred from a private hospital, and with history of blood transfusion reaction on 10th March 2022. She was a primary patient with active married life of 3 years. Her expected date of delivery was 8th of March 2022. Patient had taken only one antenatal visit at CHC Dapur in first trimester of pregnancy, with one dose of TT was given at that time. After that, patient has not taken any other antenatal visit. On 10th March, patient went to the private clinic with complaint of fever since 2 days, where she was detected anemic. Her HB was 7.4 gram percentage. 1 pint of PCV was given at that time. After that, patient developed complaint of high-grade fever, palpitation, and breathlessness. So acute febrile reaction, anaphylactic reaction was suspected, and PCV was stopped immediately. Patient was referred to LG hospital after giving injection darifylline and phentermine. On admission to LG hospital, patient was conscious and oriented. Her temperature was 101 Fahrenheit. Pulse was 120 beats per minute. BP was 110 by 70 millimeter of mercury. She was tachypneic. Her SpO2 was 96% on air. She was pale. On systemic examination, her respiratory and cardiovascular examination was normal. On per abdominal examination, 36 weeks of size with cephalic and fetal heart sound was 110 beats per minute. On per vaginal examination, it was os admits the tip, unfaced and mid position. Emergency medicine refer was done for anaphylactic reaction, and as per their advice, symptomatic management was done with PCM pint and IV fluids. On non-stress days, bit-to-bit variability was less than 5. 2 decelerations were present and no acceleration. So emergency LSES decision was taken. On admission, the HB was 9 gram percentage. Our WBC was 13,000 and platelet was 1 lakh. Our PT and APDT were raised. PT INR was 1.5 and APDT was 1.8. Our total bilirubin was raised with 2.8. Direct and indirect were also raised. Her alkaline phosphatase was 273. Her renal function tests were normal. Her D-dimer and fibrin degradation products were raised. Her fibrinogen was borderline. And after the emergency CS, her HCV became positive. During the LSES, after delivery of the baby, uterus was relaxed and hemorrhage was managed by giving injection oxytocin, carboprost, and ligation of bilateral uterine arteries. Intra-abdominal drain was kept. On post-operative day, day 1, patient was conscious and oriented. There were 4 spikes of fever, more than 100 Fahrenheit in 24 hours. Patient had tachycardia and tachypnea with 150 beats per minute pulse and 30 per minute respiration rate. Patient was hypotensive with 80/60 millimeter of mercury of BP. Her systemic examination were normal. Her drain output was 400 ml in 24 hours and urine output was adequate. Her baby was admitted in NICU for birth asphyxia. On day 1, her HB was 4.4 gram percentage with increased WBC count and platelet was only 1 lakh. Her PT and APDT was still raised and her total bilirubin was 2.5 milligram per deciliter and RFT was normal. So after she was detected HIV positive and with DIC, we gave her 1 pint of PCV, 4 pint of FFP, 4 pint of cryo, 4 pint of PRC. In antibiotics, we give her injection piperacillin and tazobactam combination and metronidazole to cover the anaerobic. 1 PCM pint for fever and 2.5 liters of IV fluids. On post-operative day 2, patient was conscious. Her temperature, there were 2 spikes of fever in day 2 and her pulse and respiratory rate were borderline and her drain output was 100 ml on day 2. Urine output was adequate. IV hydration was maintained with 3 liters of fluids. She on investigation, her HB was 6.2, WBC was 20,000, her platelets was 72,000 count. Her PT and APDT were normal on day 2. So serum bilirubin was 1.7 milligram per deciliter, which was decreasing. On day 2, we give her 2 pints of PCV and continued higher antibiotics and symptomatic treatment. On day 4, patient had no complaint at that time and there was no fever, tachycardia or tachypnea. Her drain output was less than 50 ml in second and on third and fourth day. So we removed drain on day 4 and her urine output was adequate. So catheter was also removed. Her HB was 8.6 on day 4. Platelet count were 1,21,000. Alkaline phosphate, bilirubin and RFT was normal. On treatment, we continued the higher antibiotics and IV hydration, glucose powder, and we have given her injection ferrous carboxymaltose 1000 milligram on day 4. On day 7, patient was conscious and vitally stable. Urine and stool were passed. On investigation, her HB was 10.1, WBC was 11,000, platelet count was 1,50,000, her bilirubin and SGPT were normal. So patient was discharged on post-operative day 8 after stitch removal. Stitch line was healthy and explained for follow-up visit after 15 days. On 25th March, after 15 days, she was vitally stable without any complaint. Her CBC and LFT is in normal range. So this was my case. And so I would like to say that besides doctors, patient education is must because patient had taken only 1 antenatal visit and we have to educate the patient about all the high risk conditions during pregnancy like anemia or viral infections or preeclampsia, and we have to educate the patient since first visit by doctors or by programs. And as this case was further complicated by blood transfusion reaction, which is not a common condition, but after it occurs, it is very critical decision to give another blood products. So this case should be managed only at tertiary care center.
Dr. Munjal, would you like to add something?
No, ma'am, because it was our case only. So we would like to invite comments from your side, ma'am. Yeah.
This hepatitis E, I mean, straightforward, it's hepatitis E, isn't it? Would you do all the viral markers?
Yeah, ma'am, actually what happens is in an institution, it takes time for us to get reports of those viral markers. When hepatitis E came positive, it was like already 24 hours from the time of admission. And the cesarean section was already performed. So it was difficult to take on, but then bilirubin was indicative of it. And we were suspecting hemolysis as well because she had the blood transfusion reaction.
Did you not give blood because of the reaction? Is it because the hemoglobin is only 3.4?
Yes, ma'am.
That's why you stopped with only 1 pint.
Basically, Yeah, she had history of blood transfusion
Anyone.
from the private. So it was a tricky decision, but then we did not have any other option by keeping, the emergency tray ready. We had to infuse the PCV because she was severely anemic and she would not even survive the normal labor as well. So it was a decision taken with, keeping the relatives and the patient in confidence in form of informed consent. And then we proceeded, and God's help that we could make it possible for her to survive.
See, my question is, you already know that she received a transfusion and then she had a reaction. So what extra things did you do to prevent another transfusion? You're not sure the same thing could happen. It could be worse also. So did you check, did she have any reactions? What was the reason for her having a transfusion? Should we do that before going on to the next transfusion?
Gira, would you like to reply?
The mismatch transfusion also, isn't it?
Yeah, ma'am. Yeah, exactly, ma'am. So Gira, would you like to highlight about the possibility of mismatch and the preparations? Dr. Gira?
Did you take any precautions for this case?
I think her network is down. Dr. Gira?
She's not there.
Okay. So basically, what we did was, that, as you mentioned, ma'am, there was a possibility of mismatch blood transfusion in private, maybe in an institution. So we definitely prepared ourselves with the BT reaction, the possibility of BT reaction in form of informed consent and all the medications required. So as in this antihistaminics and darifalin, and basically she had no reaction within first few minutes, like 10-15 minutes. We had one of the residents being seated besides the patient throughout the whole transfusion, and then even during cesarean section, things were very much under control in form of anesthetist looking after the running transfusion at the same time. So we had this watch while even giving PCV as well as perioperative phase, ma'am. Because no other option was there, as literature mentions that FCM would take 5 to 6 days, 7 days. Still, the robust evidence is not there. Then when to repeat the FCM dose, the second dose. But then obviously these are the limitations we had with such a low HB. So we had to start with PCV, taking that particular risk, and the reward was there. So I think the most probable diagnosis was mismatch blood transfusion in case of that private first PCV reaction, madam.
Anything? Reshma, any comments? Reshma?
Reshma, madam, you are muted actually. Yeah.
Reshma, please unmute.
Reshma. Yeah.
Reshmi? Okay.
Yeah, am I audible now?
Yeah, now
yes,
it was going on to mute. I don't know how. A very good case, an interesting case, Dr. Gira, and very well managed case, Dr. Munjal. And actually, when we look at the near miss, this comes under category 3, which is an incidental cause. Actually, hepatitis, infective hepatitis comes under category 3. And this case became a near miss because of the 3 criteria, because she had clinical findings, she had the investigations were normal, and the interventions were also there. So 3 criteria satisfied, and she became near miss. And again, it is actually it is one of nowadays rare. Actually, we don't see that much of cases of hepatitis E, and it was said that it is a very grave situation, and you could prevent the maternal mortality. That itself is very good. And one suggestion from me would be that when we not present or in near miss reviews, what we follow is a level of confidentiality. What we do is a confidential review of maternal near miss. Actually, we anonymize all the case sheets and only send to the reviewers. We have a reviewers system also. In addition to the guidelines by Government of India, we have an additional review by senior obstetricians, retired professors. So we anonymize everything. So anonymity would be an important thing. It is only that. It was a very good case, interesting case.
Thank you. Can we move on to the last case?
Thank you, ma'am. Thank you.
Thank you, Dr. Munjal. And
thank you, ma'am. Thank you.
Thank you so much.
I would like to invite our Covai OG Society to present their case. I request Dr. Chitra to introduce the speaker, please.
Make it short. Baburani.
Yeah, Yeah, I think Dr. Chitra and Dr. Ramya are already known. Only the speaker need to be introduced, or you can invite the speaker to present the
Dr.
case.
Anupriya, she's an assistant professor from PhD IMSR, and she's a very, very impressive person, very dynamic person who's going to talk to us about a very, very interesting case. One entire month, almost 1 to 1.5 months, she was behind this patient. The entire unit was behind this patient. So let's look forward to a very, very interesting case, which was really a near miss. How she did not become a mortality is God's grace. Dr. Anupriya, please. So stay back and listen to the entire case.
Sharing my screen. Yeah. Good afternoon. Good afternoon. Good afternoon to all. I thank Dr. Chitra ma'am and Ramya ma'am for giving me this opportunity to present this case. It is actually a teamwork which helped the case to save. She is a 27-year-old primary mother, 35 weeks gestation.
Slideshow. Anu?
Ma'am, could you please keep the slideshow, ma'am?
Slideshow. Stop share. Stop share. It was share screen. Yes, ma'am. Can you?
Yeah.
Yes, ma'am.
She is a 27-year-old primary, 35 weeks and 1 day of gestation, referred from a small town near Coimbatore as a case of query AFLP and sepsis by a physician. So she has been referred to us by a physician with a complaint of abdominal pain, vomiting, bleeding PV and jaundice for past 3 days and high colored urine for past 3 days. Before this presentation, during her routine antenatal checkup in her local town with the obstetrician, with the routine blood investigation, she was found to have elevated bilirubin and she was referred to the physician as a jaundice complicating pregnancy. And the physician advised her to get admitted for evaluation, but she was not willing for admission. So he got a written consent that she is not willing for admission. And he left the patient. She went back to home, and in home she was around 5 to 6 days. Then she developed all these complications and she came back to the physician with all these complaints and reduced fetal movements for 3 days. Previous antenatal checkups were uneventful, scan, everything was normal, except she had moderate anemia, for which she had parenteral iron infusion, and subclinical hypothyroidism, for which she was on L-Troxin. As soon as we received the patient, we admitted the patient in the labor ward. And on examination, she was conscious, oriented, pallor and icterus was present. Pulse rate was 94 per minute, BP was 130/80, and saturation was maintaining at 98% in the room method. So abdomen examination, uterus at term, cephalic presentation, tense and tender. FH was good during the time of presentation. And local examination, per speculum, there was no active bleeding, very minimal amount of bleeding, os appeared to be closed. And once we inserted the Foley's catheter, very minimal amount of cola colored urine, high colored urine, it was draining. So we immediately sent all these blood investigation. Hemoglobin platelets found to be normal, but her coagulation profile was abnormal. Fibrinogen was less than 30, G-dimer was 6.8, bilirubin was elevated 13.2, enzymes were markedly elevated, and her serum creatinine was also raised. So we made a provisional diagnosis of health with abruption, AFLP and sepsis. And we plan to do an emergency cesarean section, and with the blood investigation simultaneously we started resuscitating the women with the blood and blood products, and along with that we shifted the patient for emergency LSCS. Emergency LSCS was when she delivered a 2 kg female baby. Baby was also sick at the time of it, did not cry. UbGyn was 2/10 and 6/10. So baby was intubated immediately, but baby recovered in 1 week. And in intraoperative, definitely abruption was confirmed, and there was a meconium stain liquor and atonic PPH, which was medically managed, and bleeding has been controlled. Blood and blood products was started pre-op and intraoperative. And immediate post-op, she had all these problems. Fibrinogen was less than 20. We suspected whether she is going into DIC or not. There was hypoglycemia, persistent hypoglycemia. Patient was on ventilator, and pre-op, intra-op, on immediate post-op, we transfused around 11 cryoprecipitate, 4 FFP, and BP, there was a BP fall because of hypotension, and she was kept on double inotrope, adrenaline and noradrenaline. There was oliguria immediately after delivery, and hemoglobin dropped to 4.46. So we transfused 2 unit PRBC in immediate post-op within 12 hours. And we got a medical gastro and nephrology opinion because of oliguria. And on day 1, she was on ventilator and hypoglycemia persisted. She was on hypotension. And we started on higher antibiotics. Since there was hypotension and hemoglobin drop, we did a bedside ultrasound in the ICU, which showed a collection of size 11 into 5 centimeter. And on day 1, we again transfused 6 cryo, 2 FFP, and 2 units of platelets in the post-operative ward. Then we shifted the patient on day 1 to our medical intensive care unit. And week 1 in ICU, patient was still on ventilator throughout week 1 on inotropic support. So she had severe coagulation failure, hypoglycemia was there. There was persistent shock, oliguria, and because of this hypotension, she developed acute kidney injury, and last finally she was in sepsis. She also had increasing abdominal distension, and we suspected an intra-abdominal bleed, for which CT we had done a CT. CT showed large intraperitoneal collection, more towards near the hepatic region, and also there was collection present superior to the rectus. So for intraperitoneal bleed, we inserted with the help of interventional radiologists the pigtail, and we around 1000 ml of blood stain fluid was collected. And for the collection near the extraperitoneal around the wound, we did a wound exploration, and all clots were evacuated, and wound was kept open for drainage, and it was maintained with daily sterile dressing. And for oliguria and acute kidney injury, we did a dialysis, that is sustained low efficiency dialysis, which you usually do for a critical care patients. And patient was started on higher antibiotics with the help of our infectious disease specialist. And also for sepsis, he suggested antifungal fluconazole to be started. Then patient was on anti-coma measures and Ursocol. And week 1 totally we transfused PRBC 6 units, FFP 5 units, platelets 12 units, and cryoprecipitate 8 units. In this 1 week, she went for cardiac arrest 3 times, and which was resuscitated. She was revived from the cardiac arrest. And after 1 week, with the help of our gastro team, we refined our diagnosis to be a jaundice complicating pregnancy, hyperacute liver cell failure, possible etiology to be AFLP and hepatitis C. And then this week 1, she had all these complications of AKI. She was on metabolic and lactic acidosis, hypotension, and sepsis. And end of first week, she was still on ventilator and inotropic support, but conscious improved, hemoglobin improved, PT-INR came under control, urine output also improved, viral markers were negative, so hepatitis E was excluded. But still she had sepsis, thrombocytopenia, urea started to increase, and because of this major massive transfusions, she developed acute respiratory distress syndrome due to this transfusion related acute lung injury. And all these blood transfusion, what we transfuse till now with the help of this thromboelastogram, which is a graph which helps us to monitor the coagulation profile of a patient, especially the platelet function and the fibrinogen level. I have a picture graph of this thromboelastogram, which if time permits, I will explain this later. And week 2, patient still on ventilator and inotropic support. For no reason, she was under hypotension. One day she will, BP will increase, we'll try to reduce the dose, and again in one day midnight, again she will go in for hypotension, again we'll increase the support. She could not be weaned from the inotropic support or ventilator in the week 2, in the beginning of the week 2, but PT-INR was stable, liver was apparently recovering, and dialysis was done for a acute kidney injury, and she had an Acinetobacter sepsis, and she was on higher antibiotics, antifungal. Then again in week 2, we transfused 4 units of platelets because of platelet fall, and abdominal distension was increasing. And end of week 2, we planned for tracheostomy with the help of our ENT team, but they tried to postpone it, but by the time end of week 2, patient improved and she was weaned to CPAP. And early week 3, she was extubated and patient was maintained on NIV. Inotropic dose was able to be reduced, but patient developed fever spikes in week 3. Again, blood culture showed ESBL and Klebsiella infection, and antibiotics were changed accordingly. An antifungal was continued, urine output was adequate. Chest X-ray showed right lobe consolidation and effusion, urine output was adequate, and CBD was removed on day 21. And end of week 3, she was on intermittent BiPAP. Acute kidney injury was recovering, sepsis was resolving, but ARDS was there. And week 4, she improved. She was stable and she was able to maintain the saturation in the room air, and she is tolerating the oral diet very well. Fever spike started to reduce. One fine day, pictal fell off by itself, but ultrasound showed intra-abdominal collection seems to be reducing. Antibiotic was continued, and tablet Ursacol was continued, and liver function test, which was showing, which was reducing by the end of 4 weeks, it started to increase slightly. On day 26, patient was shifted out of ICU. And in the ward, she was stable, urine output was adequate, sepsis resolved. So we thought of suturing the cesarean wound, but we did a resuturing, but there was persistent discharge and collection. So again, we have to remove the sutures, open the wound, and evacuate the hematoma. And wound swab showed again Klebsiella infection, and antibiotics changed accordingly. And we got a plastic surgery opinion regarding the wound healing, and he suggested to allow it to heal by secondary intention. And in the ward, we also transfused 1 unit of PRBC. And post-operative day 40, she has been discharged, and at the discharge, her hemoglobin was 8.4, platelet was 3 lakhs, bilirubin was 5.4, SGOT and SGPT were elevated, and wound care, we advised her on daily dressing and allowed to heal by secondary intention. So this is the investigation trend of the patient. So immediate post-op, there was a fall in HB, and with the transfusion of PRBC, hemoglobin was maintaining, and again at the end of 2nd week, there was a fall and there was an increase, and each time there was a fall, we used to transfuse on PRBC. And this is the trend of her coagulation parameter. APTT was raised, PT-INR was raised initially, and slowly it started to reduce, and by the end of 1st week, it became to normal and it was maintaining. But platelets were reduced for around by the middle of the 2nd week, and slowly again it started increasing. Fibrinogen level initially was very less, and up till by transfusing all this cryoprecipitate, by end of 1st week it came to 150, and after that we stopped transfusing. We were just monitoring, and once it reached to the normal level, we stopped monitoring this fibrinogen trend level. And this is the bilirubin. Initially, there was a increase in bilirubin. It reached maximum up to 24 because of this acute hyperacute liver cell injury, and then it started to fall. But again, it started to rise, which was attributed to the hemolysis of the intraperitoneal collection, an increase in the bilirubin level, and slowly after that, bilirubin level has reduced. But during discharge also, it was 5.4, but it did not come to the normal level. Gastrotin told slowly the liver will improve, so the bilirubin will gradually come down. And this is the trend of the renal function test. Creatinine was raised in the beginning, and slowly it became to normal. Urea which was increasing also came back to normal at the time of discharge. So the final diagnosis of acute fatty liver pregnancy was made, and she had all these complications: coagulation failure, hypofibrinogemia, acute kidney injury, cardiac arrest. She was in shock, intraperitoneal collection, ARDS, and sepsis. So her total hospital stay was 40 days. ICU stay was 26 days. Total units of PRBC transfused were 9 units, FFP 9 units, platelets 16 units, and cryoprecipitate 19 units. In this 40 days, husband was very supportive. In no point of time he withdrew from the treatment. He was having full faith in us, and amounting to the cost in the ICU and hospital stay in a private hospital, he had a full faith, and in no time he withdrew that I'll take the patient to a government hospital. I can't spend like that. He did not even tell in this 40 days because he was having very much positive attitude on us. So which also helped to save the patient. And she came after 1 month for us to the review. Patient was stable, wound was healing, and hemoglobin was 12.1. Platelets was 5, INR normal, bilirubin was reduced, enzymes were marginally elevated, urea creatinine was normal. And after 1 month, patient had this stridor, noisy breathing difficulty, and we referred the patient to the ENT, where intubation granuloma was diagnosed, and she was admitted under ENT, and tracheostomy with granuloma excision was done under GA. But patient improved, and she with this tracheostomy wound healed very much. And after 5 to 6 months also, she developed all these trauma and morbidity. She developed some borderline intellectual problems, depression, all those things, for which she was under psychiatric treatment. Finally, patient was Fine. So we give a big thanks to all the team who involved in the patient care. Because of them, we could help to save the patient. Our OG team especially, and all the gastroenterologists, ICU team, blood bank, PG, CRRIs, and staff nurse, those who are involved in the patient care. So what we learned from the patient is referral at correct time and correct place. Because this patient went to a physician and spent after diagnosing to have jaundice, she spent 4 or 5 days in her house. So this is very important, referral to correct place and to correct time, and prompt action, and importance of teamwork. And we also learned about tech from how to use this thromboelastogram from this patient, and being optimistic. That is because of the husband. Throughout the treatment, whenever we counsel him, tell the prognosis of the patient to the husband, she will become all right, ma'am, no problem, I have faith. So this being positive is very important. And thank you to the whole team. This is our team, OG team, involved in the patient care. Thank you to all. Thank you for the.
Thank you, Dr. Anupriya. You really took us through this. I relived this Anuvardhini, because I remember all the 1.5 months, how hard we suffered. At least 2 or 3 times per day, we will do rounds. And like you said, the take-home points from this is the teamwork. In fact, if you'd seen, not a single super specialist was not involved. We had the plastic surgeon, we had the nephrologist, we had the hematologist, we had the intensivist, we had the infection committee. So everybody was involved and everybody was under the same roof. I think that was the most important, which helped the patient to survive. In fact, you might be in a center where all have to be called from different places. So that made a lot of difference for this particular person. Everybody was there in-house. So that was one of the greatest points which I think led to this person surviving. That is one. And we've done, so many times we had dialysis. And the other one was, I think because of this acute fatty liver pregnancy, there was so much of coagulation failure. In fact, I've seen many patients with acute fatty liver pregnancy, the coagulation failure somehow doesn't become moderate in spite of massive transfusion. They go on having bleeding. So that was one of the most important drawbacks, which we could timely detect and then do. And I think the best part, instead of opening up, we were wondering when so much of when we saw her on maybe the second midweek, she started becoming so breathless because the abdomen was becoming distant. She was developing distension because of intraperitoneal bleed. So wondering what would we did not want to touch her. But the only thing I think which saved us the most that time was putting in a pigtail. We put the pigtail and then after the fluid drained, she was feeling much better. I think that was a very good point which we did in that case. And as I said, the teamwork. And like you said, in spite of being so many days, patient did not want to go away. And the bill was enormous because 26 days she stayed in the ICU. And for this, we learned how to create this WhatsApp group and then send the message across to everybody. So a lot of money poured in. So that is why they could also continue the management, because many patients, once we go to a private center, the patient cannot afford the bill. So we told them, okay, this is one option that you could go ahead and try to get your WhatsApp group and then try to contact many people. And in that, they got a lot of funds, which helped her to continue the management. I think all this put together, financial support and the emotional support plus entire teamwork, was the one which was helpful in this case. Thanks so much. I really remember her. I will never forget this Anuvardhini. Okay. Any comments, Reshmi?
Yes, an excellent case. Actually, it was so, hearing the history, excellent teamwork, madam. Excellent. The case was presented very nicely. The case was managed also very nicely. Chitra ma'am, kudos to you. An excellent case and so many lessons to be learned from the patient and the importance of support from the healthcare workers, the team, and also that is also so much important. And most of our near-miss review, the positive aspects which we found was the early involvement of multidisciplinary team. That was the one single thing which went a long way in saving the patient, because whenever we review the maternal deaths and the maternal near misses, we see that in near miss cases, there is a tendency, we see a trend that the early multidisciplinary team are early available. Maybe that is one single point which helps determine whether the mother survives or goes on to a near miss. So the MDT was superb, I presume, because all of the departments were involved, and they were involved in the appropriate time, not too late also. That was the most important, and very nice to see the lessons learned and very nicely presented. I think it was Dr. Ramya who presented.
Anupriya.
Yeah, Anupriya. It is written as Dr. Ramya. That is why. Okay, Dr. Anupriya, very nicely presented, please. Okay.
Any comments from the others?
Yes, ma'am. I would like to comment that she had very meticulously presented the case stepwise, and the lessons learned was really very nicely presented at last. What we really learned from all these mistakes or the emergencies. One more thing, like the earliest we detect an emergency, the earliest we get the help, the better the outcome, and we can save the mothers. That is really a big take for all of us. We shouldn't wait ki ab ruk jayega, the bleeding will come down, or whatever complication. We shouldn't delay. Delay is deadly. So that is a very important point. Well presented, Anupriya.
Thank you.
Thank you.
Madam, we will come to closing.
Yeah.
I congratulate Patna Society, Ahmedabad OG Society, and Lucknow OG Society, and our own society for making such a nice webinar, which will be useful for all the practicing obstetricians. Those who have missed attending this will be given a chance to go through their website probably. I request everybody to go through this and spread the message to your friends so that this will be useful for everybody. And now I invite Dr. Ramya to give a vote of thanks. Welcome.
I take great pleasure in giving the vote of thanks on behalf of our Covai Society. I would like to thank Dr. Mandakini Madam, Dr. Ramani Devi Madam, who had graced this webinar, and Dr. Reshmi from Thrissur for having given valuable opinions. I also thank the different societies who could take part in spite of their busy professional and social commitments. From Patna Society Secretary, Dr. Supriya Jaiswal Madam, and the speaker, Dr. Monica Anand. Ahmedabad Society Secretary, Dr. Munjal Pandey, and speaker, Dr. Gira. Lucknow Society President, Dr. Yashodhara Pradeep, and Dr. Shilpa Singh, and speaker from our own society, Dr. Anupriya. I would also like to thank all the office bearers of our society, Dr. Chitra Madam, the President, Dr. Manonmani Madam, the Vice President, Dr. Reena Madam, Secretary, and Dr. Baburani Madam, the Joint Secretary. The Shield Connect and the event manager, Priya, who had always stood by us during all these webinars. And also best wishes from our society to Mandakini Madam, Ramani Devi Madam, and Supriya Madam for the forthcoming elections.
What about me?
This is from our society to all the madams.
You are never missed, madam.
Thank you.
Thank you. Dr. Chitra,
Thank you so
all
much.
the best to you for your elections.
Thank you. Thank you. Thank you all of you all for having come and then spent so much of your time. It was a very wonderful, very useful webinar. A lot of points we learned, different cases. I think that made it very, very interesting. Thank you so much, all of you all.
Thank you, madam.
Thank you, ma'am.
Thank you, ma'am. Bye-bye.
Thank you, madam.
Thank you,
Thank you,
Reshmi.
Thank you. Your input was really good.
Thank you, ma'am.
Yeah, Dr. Reshmi, really very nicely given, pointed out at every case. Very nice.
Thank you, ma'am.
Nice,
Leave now?
Reshmi.
Yeah.
Bye, ma'am.
Bye.
Bye.